The topic of discussion today is uveitis and Lyme's disease. As usual, we are going to start with the introduction. Lyme disease or borreliosis, like syphilis, is caused by a spirochete. The responsible organism Borrelia burgdorferi is transmitted through a tick bite, with deer being an important vector. An adult tick can be distinguished from a head louse by tick having 8 legs. It is an arachnid, and the louse 6, though larval tick can have only 6 legs. The disease is endemic in regions of North America, Europe, and Asia, but can be difficult to diagnose. The diagrams here show the transmission of Borrelia burgdorferi from deer and rodents to the tick, and eventually the tick bites the human being, and resultant vector is transmitted. The other figure here shows the presence of tick in an eyelash, which can be an important finding on the slit lamp examination. Now, the course of disease is very important as well. In stage 1, an annular skin lesion appears several days after the bite, which is called erythema chronicum migrans in 60 to 80% of patients, which is often accompanied by constitutional symptoms, which might include fever, fatigue, myalgias. Sometimes it is associated with meningeal irritation, hepatitis, and pharyngitis as well. This is followed by disseminated Lyme's disease, which is the stage 2 and constitutes neurological, for example, cranial nerve palsies, meningitis, cardiac, 4 to 8%, for example, arrhythmias, and other manifestations like paralysis, like Bell's palsy, and pain in the site of bite, and expansion of the rash. Later on, in stage 3, complications include chronic arthritis of large joints, polyneuropathy, and encephalopathy. The muscle movements might get abnormal, and numbness and tingling can also be a feature. Myalgias and cognitive impairment can also be seen. The diagram here shows the erythema migrans chronicum in the stage 1, the site of tick bite. Systemic features are followed by, of course, the topic which is relevant to us, the ocular features, which are varied and tend to occur in established stage 2 and stage 3 late disease. Uveitis is relatively uncommon, but it can be anterior, granulomatous, or non-granulomatous, intermediate, which is the most common type, or posterior, including multifocal choroiditis, vasculitis, or neuroretinitis. Other manifestations include early in stage 1, transient conjunctivitis, bilateral stromal keratitis, episcleritis, scleritis, orbital myositis, optic neuritis, papilledema, and ocular, motor, and facial nerve palsy in up to 25% of facial nerve palsy in endemic areas. Next are the investigations. Serology should be performed at least a month after infection, but false positives can occur. PCR of cerebrospinal fluid or synovial fluid is performed in appropriate cases. Diagnosis relies on a combination of clinical features and positive serology. Co-infection with other tick-borne disease is also possible. Coming towards treatment, treatment of early acute disease is highly effective and involves oral doxycycline, but not in children or in pregnancy, amoxicillin, or erythromycin. Untreated, many patients with early or asymptomatic disease will experience no further problem. Patients with established disease, however, including ocular, may require extended intravenous penicillin or ceftriaxone. Keratitis and uveitis need steroid treatments. Systemic steroids should not be given without concomitant antibiotics. Appropriate personal protection, which is clothing, insect repellent, should be adapted in endemic areas to reduce the risk of tick bite. Lyme disease vaccine is available but does not offer complete or prolonged protection. So that's where we'll wrap up the subject and conclude our topic. If you like this lecture, please click on the like button and subscribe to the channel. Thank you all.